and we cannot change our basic biology, our endogenous estrogens. And we heard a little bit in Ellen's talk about menarche and menopause. Some may argue that there may be things that you can do in terms of timing pregnancy, but those are the non-modifiable factors. So what are the things that we can do something about? What are the modifiable risk factors? One is endogenous estrogens in terms of breastfeeding. We can certainly encourage breastfeeding. We can reduce exogenous estrogens by reducing hormone replacement therapy. We've heard a lot today about obesity and physical activity, and certainly that plays a role, and alcohol. So let's do a deeper dive. Encouraging breastfeeding. I don't know about you here in Turkey. Certainly in the US, there is a national shortage of formula, which is unfortunate. But one of the things that we know is that when we encourage breastfeeding, we actually reduce the risk of developing breast cancer by about 4.3% for every 12 months of breastfeeding. We also know that reducing exogenous hormones, so hormone replacement therapy, that has occurred for more than 5 years is associated with a 35% increased risk of breast cancer versus those who never took hormone replacement therapy. And all of us are familiar with the Women's Health Initiative, which found that combination estrogen and progestin therapy was associated with a 24% increased risk at 5.2 years. There was a study that came out just earlier this year that found even in breast cancer survivors, if they were taking combined estrogen and progesterone, they had an increase in their breast cancer recurrence rates of 46%. Now, all of you are now experts on obesity and encouraging physical activity. We know that if we encourage women and they engage in moderate to vigorous exercise 3 to 4 hours a week, they can enjoy a risk reduction of breast cancer by 30 to 40%. We know that overweight and obese women have a 30 to 50% increased risk of developing postmenopausal breast cancer. And that risk is stratified based on how obese you are. So there's a 12% increased risk for every 5 kilograms per meter squared increase in BMI. There have been 2 meta-analyses that showed anywhere between a 43 and 80% increase in premenopausal triple negative breast cancer in obese patients. One of the things that Ellen mentioned, which is true, is that if you look at all premenopausal breast cancer, especially those that are luminal A, so estrogen, progesterone receptor positive, HER2 negative breast cancer, obesity is actually somewhat protective. We try not to advertise that too much because it certainly can increase other risks. Alcohol, we know, increases your risk of developing breast cancer as well. It's one of the only dietary factors that has been well studied. But we know that in 15 to 30 grams of alcohol, so even 1 to 2 drinks per day, increases your risk of developing breast cancer to 30 to 50%. And that relative risk increases by about 7% per 10 grams of alcohol consumed per day. So aside from reducing those risk factors, how else can we reduce the risk of developing breast cancer? Many of us know about primary prevention in the form of chemoprevention and prophylactic surgery. So for chemoprevention, we talk about tamoxifen, and for our postmenopausal women, raloxifene or aromatase inhibitors, and we'll dive a little bit more deeply into that. Many of you are familiar with the P1 study, which found that tamoxifen reduced the risk of breast cancer in both pre- and postmenopausal patients, essentially cutting the risk in half. For atypical hyperplasia, it actually had an even more significant risk reduction, reducing the risk by about 85%. And in those who had LCIS, it reduced the risk by about 60%, although this did not hit statistical significance, primarily due to a low sample size. And when patients were followed for 7 years, we found that this risk reduction was maintained. The IBIS-1 trial also found very similarly that tamoxifen continued to reduce the risk of breast cancer at a median of 16 years. Again, the hazard ratio for those who were on tamoxifen for 5 years was 71%. So again, roughly a 30% reduction in risk compared to placebo. Now, tamoxifen is not without its risks. We know that it does increase your risk of endometrial cancer, of venous thromboembolic events, cataracts, and it can also cause hot flashes, vaginal discharge, etc. But for many patients, it is well worth it if they are at high enough risk of breast cancer to consider taking chemo prevention. What about for postmenopausal patients? Well, as I mentioned, we have a number of options for postmenopausal patients in addition to tamoxifen. So the STAR trial, the study of tamoxifen and raloxifene, followed patients who were randomized either to tamoxifen or raloxifene for 81 months. And raloxifene maintained about 76% of the effectiveness of tamoxifen in reducing the risk of invasive cancer, and was not associated with an increased risk of uterine cancer. And it actually had a slightly lower risk of thromboembolic events than tamoxifen. So certainly is an option for some postmenopausal patients. We have several trials now that have looked at aromatase inhibitors. The MAP3 trial from the NCIC looked at exemestane, which found that that reduced the risk of breast cancer by about 65%. Again, a nice reduction for the atypical hyperplasia and lobular carcinoma in situ group, reducing their risk by around 65%. The IBIS-2 trial looked at a different aromatase inhibitor, anastrozole, again, finding a roughly 50% reduction, and again, roughly 70% reduction in those with atypical hyperplasia or LCIS. So certainly for patients who are at increased risk, either because of a invasive cancer or because of personal or family history, or because they have a history of atypical hyperplasia or LCIS, these are all options, and they are not associated with an increased risk of thromboembolic or cardiovascular events. Now, for the surgeons in the crowd, I know on Wednesday I left people perhaps with a little bit of a pessimistic view that surgeons may be out of a job one day in the future. There still may be a role in the sense that we do know that prophylactic surgery is effective in reducing risk. Prophylactic oophorectomy can reduce the risk of breast cancer by about 50% and reduce the risk of ovarian cancer by about 90%. And certainly prophylactic mastectomy can reduce your risk of breast cancer by 95%. We know that that's the most effective way to reduce your risk. And these days, we have very nice options in terms of reconstruction, which can be done at the same time, that gives women a nice alternative. But in order to really understand how much is a 95% reduction in my risk, it's important for you to understand what that risk looks like. And so there are a number of ways that we can think about assessing risk. So one of the important criteria, and I think something that has really blossomed over recent years, is an understanding of genetics. Now that we have the Human Genome Project, now that the patents for breast cancer genes have been overturned, we now have the cost of genetic testing plummeting, and we're able to now offer genetic testing to more women. You can see here that it really does make a difference. If you look at the average American woman, her risk of developing breast cancer by the age of 70 is about 12%. But if you have a BRCA mutation, depending on whether it's BRCA1 or 2, your risk can be anywhere from 45% all the way up to 70%. If you have Howden syndrome or P10, 25 to 50%. We heard earlier this morning in the childhood leukemia section of the symposium that leukemia is a factor affecting many children. And I know one of the things that's important for Lösev is thinking about holistically the whole family. Well, one of the things to think about is when you have a child who has Löseve syndrome, to think about what is the risk of the parents, the siblings, and so on. Certainly for patients who have a TP53 mutation, their risk of developing breast cancer by the age of 70 is 49 to 60%. So important considerations in terms of genetics. Outside of genetics, there are other models that we can use to think about other risk factors, including family history, history of ADH and LCIS, a history of chest wall irradiation, particularly in their youth. Women who have been exposed between the ages of 10 and 30 are at significant increased risk of developing breast cancer. And there are a number of models that you can use to predict lifetime risk, the Yale NCI model, Tyler Cusick, the Pro, and so on. Now we know that, as I mentioned, the cost of genetic testing has really plummeted. And now patients can often get kits that they can use and send off in the mail and get their results back. It's important, I think, however, to really funnel this through a healthcare provider, somebody with a genetic background, so that they can interpret this. Because we know now that this is not simply about the high penetrance genes like BRCA1 and 2. We now know that we have low penetrance genes that are highly prevalent in the population. And so these days, when we have panel testing, you'll find that the rate at which you will find a pathogenic mutation goes up, but so too does the variance of uncertain significance. And so it's important, I think, to counsel patients about what exactly does that mean and how will they address that in terms of risk reduction. So moving now into secondary prevention and screening and detection, there are a number of modalities that we look at. So self-breast exam, clinical breast exam, mammography of various types, ultrasonography, MRI, others. And I lump into that category a lot of modalities that have been marketed by some to clinicians, some of which have no merit at all. And I put into this bucket thermography and others. And so we won't spend much time looking at those others, but I will give you some of the data with regards to the others on this slide so that you can understand the clinical trial data where we have that for each of these modalities. So in terms of self-breast exam, there have been 2 large randomized controlled trials looking at self-breast exam in low to middle income countries as a means of screening. Because remember, if you are in a low to middle income country, you want to screen your population. We know that 85 to 87% of women in low to middle income countries, and remember breast cancer is the #1 malignancy in many of these countries, is presenting at stage 3 or stage 4. So if we can downstage, even with something as simple as self-breast exam, we can potentially save a lot of lives. And so this was the rationale in going behind thinking about self-breast exam as a cost-effective means of screening patients. Unfortunately, however, this did not pan out. So the Shanghai randomized controlled trial looked at over 266,000 women randomized to self-breast exam versus control. They were accrued to this study between 1989 and 91, followed through 2000. But the breast cancer deaths were the same in both groups, so 0.1% in both groups. And you can see here the cumulative relative risk pretty much exactly at 1.0. What they found, very similar to the Russian study, and here I show you a meta-analysis, was that in the group who was randomized to self-breast exam, they were more likely to seek medical advice, they were more likely to undergo biopsy, but the chances of finding a breast cancer or dying from breast cancer was equivalent in both groups. And so, based on this, self-breast exam really has not panned out to be a very effective modality for screening patients. And even in the US, the American Cancer Society now no longer has made a strong recommendation for self-breast exam as a result. What about clinical breast exam? Now, clinical breast exam has also been very robustly studied in low to middle income countries. This is a pretty famous trial that came out in the JNCI in 2011 from India. They looked at, this was a clustered randomized controlled trial looking at over 115,000 women, randomizing them to clinical breast exam versus control. And what you can see was that more cancers were diagnosed in the group who had clinical breast exam. Clinical breast exam was found to have not a great sensitivity, but 51.7%, but a reasonably decent specificity of 94.3%. Importantly, however, if you looked at the number of patients, the proportion of patients who were diagnosed in early stage versus late stage, it favored the clinical breast exam, and vice versa for the late stage. So you had fewer late stage patients when you had a clinical breast exam, essentially causing us to have exactly what we wanted, a shift in the stage of cancers. So that instead of picking people up when they're already metastatic, you can now downstage them, pick them up when they're stage 1, stage 2, when breast cancer is really treatable. And these data have been replicated in a number of studies, and it has been found that this is actually cost effective. So here I show you a cost effectiveness study that came out of Vietnam. They found that the incremental cost effectiveness ratio, or the ICER, for clinical breast exam for women between the ages of 40 and 55 was $994 US per life year saved. The WHO has recommended that cost-effective strategy should be less than 3 times GDP per capita. So if you think about the Vietnamese GDP per capita at the time of this study, which was in 2013, was roughly $1,070. This is well below that. And they did a sensitivity analysis. So what happens if our participation rate falls to less than 70%? What happens if the cost increases? What happens if we want to screen more people? We want to increase it instead of from 40 to 55. What if we want to do from 35 to 55? What if the specificity drops? What if we want to screen even more people? You can see that across the board, this was a cost-effective strategy. And in India, there was another cost-effectiveness analysis where they actually found that doing clinical breast exam annually between the ages of 40 and 60 was nearly as efficacious as biannual mammography for reducing breast cancer mortality, but it incurred only half of the net costs. Now, for countries that are a little bit more affluent, remember we need to kind of think about things in a resource-specific way. Many of you may have seen these data, which show you the randomized controlled trials to date, looking at the effectiveness of mammography screening. And you can see that mammograms save lives, right? The majority of the data show us that the effectiveness is really in this group. Below the age of 50, this 95% confidence interval does cross 1. Over the age of 70, it also crosses 1. But the majority of the studies, and where we see absolute differences in terms of mortality, is in the group between the ages of 50 and 69. And so because of these data, and because of the interpretation of the data, you can see that a number of organizations, and I apologize that these are a little bit North American centric, have varied in terms of their recommendations. So the U.S. Preventative Services Task Force, which is very data driven, has said, you know, start screening at the age of 50. You can discuss it younger than that for people who are at particular risk. Biennial screening, stop at the age of 75, because this is what the data are the strongest for. On the other hand, if you look at the American College of Obstetrics and Gynecology, they're still recommending starting at the age of 40, doing annual mammography and never stopping. And everybody else is somewhere in between. So how do we think about what is right for a given population? I think that there are a number of factors to consider, and here I group these into what I call the 5 Ps. Think about your population. What is the age distribution? Do you have a very young population who develops breast cancer? Is it more appropriate to start screening earlier? Is it appropriate to start thinking about screening with a different modality, perhaps ultrasound as opposed to mammography because those patients may have denser breast tissue? What is the life expectancy of the population? Are there cultural beliefs that play into this? What about other factors that may affect adherence to a particular screening regimen? Do you have the personnel and the equipment, not only in terms of the machinery, the mammogram machines, but thinking about all of the other things? Do you have the radiologist to interpret the mammograms? And if you have that, well, do you have the stereotactic equipment so that if you find something, you can biopsy it? And then do you have the equipment to localize that so that the surgeon can then take out what you now cannot feel? And if you can take that out, well, do you have the radiation facility so that those patients can enjoy breast-conserving surgery? Think about the placement. Are you going to offer this in central locations? How will patients get access to these facilities? Do you have mobile mammography vans? Or how do you transport patients to get the screening? And then, of course, there's the big issue of cost. We heard about this this morning as well. What about payment? It's one thing to offer screening, but if nobody can afford the screening, or worse yet, the screening is offered for free, but then they cannot afford the treatment, then what is the point? And finally, I think it's always important to think about the pitfalls, because while many people like to kind of follow the lead of where the US has gone with annual mammography starting at the age of 40 and going forever, even the US is now thinking about whether that was the right strategy as we now face yet another epidemic of overdiagnosis and overtreatment, thinking about the other issues that go into screening in terms of pain, anxiety, false positives and negatives, the radiation exposure, particularly with mammography, etc. So what does the WHO recommend? In low resource settings with a weak health system, where the majority of women are diagnosed at late stages and mammography is not cost effective nor feasible, they really recommend thinking about screening symptomatic lesions and offering prompt treatment. So clinical breast exam is the promising approach for these patients. In those who have relatively strong health systems, however, there you can start thinking about an organized population-based mammography screening program. If such a program can be met by the healthcare system and their shared decision-making, and even there, the recommendation is for screening every 2 years. I tried to do a little bit of digging into what's the situation here in Turkey, and I found that in 2004, the Cancer Control Department recommended biennial mammographic screening for women 50 to 69 based upon European guidelines. And there was a screening program that was offered starting in 2009 to 19, the data of which was just published last year. The acceptance rate was reasonably decent, 71.7%. Breast cancers were diagnosed in 130 of those women, median tumor size 12 to 14 millimeters. There were about 7% that were missed by mammography, but then again, they were picked up either by MRI, clinical breast exam, and 7 were picked up by ultrasound. Now the European Society of Breast Imaging and 30 national radiology bodies, including Turkey, are recommending biennial screening mammography for this population as a first priority, then extending to the older population as a second priority, and to a younger population as a third priority, and certainly thinking about digital mammography. This was a study that looked at mammography uptake in Turkey. This was before that study was published, where they found in looking at the state of affairs in the National Chronic Diseases and Risk Factors study that was put out by the Ministry of Health in 2011, that only 19% had had a mammogram up to that point. I think with your new screening programs, that certainly may change. But when they looked at factors that affected that, you can see, not surprisingly, older age group increased the risk, the rate of mammography, as did being better educated, being more health conscious in terms of, engaging in physical activity and eating more than 5 servings of fruits and vegetables. Interestingly, there's also some opportunistic screening, it seems, because those who had a higher waist circumference or more than one chronic condition were also more likely to engage with having had a mammogram. Lower rates for those who were single, who were in rural areas, and those who were in the eastern part of Turkey, which gives you some thought about where you might allocate your resources in terms of a population-based screening program. So certainly this was another study that came out of Turkey looking at other barriers to screening, which they kind of grouped into systematic barriers, including insurance and accessibility and attitudes of healthcare professionals, personal barriers with fear and embarrassment and perception of breast cancer, lack of motivation, socioeconomic factors, and then the social barriers of culture and stigma. I heard that here you've moved already to digital mammography and 3D mammography. So you can see here that that's certainly something that we've done in the US as well. Here's a digital mammogram. This looks like this is just fibrous tissue, but certainly when you apply tomosynthesis, you get the impression that there's something there. Coming soon, perhaps, is contrast-enhanced mammography. This is still in the research realm, even in the US, but I think may hold promise, particularly for those at high risk. We talked a little bit on Wednesday about ultrasonography, particularly for those with dense breasts, younger patients. There was a randomized controlled trial that came out of China looking at high-risk women, where they randomized people to ultrasound, mammography, or both, and found no difference in detection, specificity, or positive predictive value between the groups, but ultrasound was significantly cheaper. So certainly for those populations where you have a younger population, you want to avoid exposure to radiation, ultrasound is something that you can readily teach. There was a study that was done in Tajikistan where nurses and lay healthcare workers were taught ultrasound, and certainly found that to be helpful in terms of downstaging. What about MRI? Not really ideal for routine screening. It's expensive. There's a high false positive rate that leads to excessive biopsies. People can be claustrophobic. We don't know about the long-term impact of gadolinium deposits in the brain. Certainly you can't use it for people who have metal. But for those who are at high risk, so those who have a BRCA1 or 2 gene mutation, who have a 25% or greater lifetime risk by a BRCA-PRO or a similar model, who've had chest wall radiation at a young age, or who have Leeper-Meaning or Cowden syndrome, it may be something to consider given that these patients are at higher risk. Now, the Breast Health Global Initiative is one that really starts to think about what are best practices in various settings based on resources. So you can see that for those low to middle income countries where they really just have basic resources, you may not be able to afford much more than basic breast health awareness and clinical breast exam. But I think that where we are here in Turkey, we are either at enhanced or maximal, maybe in between these two, where we're offering diagnostic mammography, certainly opportunistic mammographic screening, and moving more towards population-based mammographic screening and other imaging technologies as appropriate. So in summary, and I apologize for going as quickly as I could, breast cancer remains the leading malignancy affecting women. There are a number of prevention strategies, both primary prevention and secondary prevention. And when we think about screening, it's really important to think about it in terms of a resource-based framework. So with that, I will close. I will thank you again for your attention and for the opportunity to present.
Thank you very much for your detailed and informative speech. Thanks. Is there any question or comment from the audience? Salondan katkı ya da soru var mı acaba? Buyurun lütfen.
Thank you very much for the nice presentation. I'd like to ask about the tamoxifen. you show that you are given them for 60 years, something like, for the prophylaxis, right? So did you adjust your population for the age, obesity, because you know tamoxifen would have resistance in the end. So how did these patients or the healthy individuals in a way end up?
Yeah, so to my knowledge, you're quite right. We know that obese patients do have tamoxifen resistance. To my knowledge, the P1 trial did not exclude these patients. I don't believe that I have seen a stratification based on obesity, but it certainly would be something to look into to see whether in fact they enjoy less risk reduction than others. But certainly something to look into, yeah.
Dr. Chagpar, may I ask a question? In your routine clinical practice, do you recommend screening sonography as an adjunct to mammography for average risk women?
I'm sorry, can you repeat?
Do you recommend screening sonography in addition to the mammography for dense breast for average risk women?
Yeah.
Not in high risk population, for average risk women for dense breast.
Yeah, so here's the issue. Routinely, historically, for dense breast tissue, we know that there is an increased false negative rate associated with mammography up to 15%. And as you know, in the United States, there was a very big advocacy movement that actually spurred on laws that patients had to at least be informed of their breast density and offered ultrasonography for dense breast tissue. Connecticut, where I live, was one of the first states to do that. So I find that many patients who have dense breasts will get ultrasound. Having said that, I think that now that we have moved to tomosynthesis, I'm finding that the rate at which we need the ultrasound is going down, because with tomosynthesis, as we take finer slices through the breast tissue, we can get such a good visualization that it becomes less and less relevant. Okay.
Thank you very much for your excellent presentation. I wonder, in the male patient, is there any primary prevention in male breast cancer?
Yeah, so great question. You know, this has not been studied. It's one of the huge disparities that we face, right? We don't have good trial data on screening. We don't have good trial data on prevention. We don't have good trial data on treatment. We treat men as though they are women, which is unfortunate. However, so in terms of primary prevention for men with breast cancer, it's hard to say the benefit of tamoxifen. We know that most men will get ER/PR positive breast cancers, but we don't know whether treating them with tamoxifen will help. We do know that many men, some men, particularly with a BRCA2 gene mutation, we know that they have an increased risk of having a BRCA2 gene mutation, will opt for bilateral mastectomies, which will give them maximal risk reduction regardless. So we do not have hard data on that. Okay.
Thank you for your presentation. My question is about germline testing in patients with breast cancer. Do you still use clinical criteria as recommended by the guidelines in your practice, or is it time for screening, universal screening for everyone?
Yeah. So, so this is a great question. As you know, the NCCN has particular guidelines for germline testing, right? So family history, bilateral breast cancers, having ovarian cancer, having male breast cancer, and so on and so forth. As you also may be aware, it was in 2018, I believe, the American Society of Breast Surgeons came up with their own guidelines, which basically said anybody with a breast cancer should have germline testing, simply because the cost had plummeted and it may affect treatment decisions. And so I think you can justify it either way. In our practice at Yale, we still are a little bit more following guidelines as opposed to offering it to everybody, not because it may not benefit everybody, but simply because there is a national shortage of genetic counselors. And so that's one thing. The second thing, though, I think that is important is that you can use your own kind of gestalt, your own rubric of thinking about what is the probability of this patient having a germline mutation. So if you have an 85-year-old who presents with a 5-millimeter invasive ductal grade 1 ER/PR positive, HER2 negative, node negative breast cancer who has no family history, just based on your gut, you're going to think that that patient has a very low probability of having a germline mutation. And the other thing to think about, so there is cost, although the cost is very low, but the other thing to think about, and this is something that does give me pause, is that these days, when we do germline testing, we're doing panel testing, right, for the majority of patients. So let's suppose you have that patient and you test them. And let's suppose now they come back with a CDH1 mutation, a pathogenic mutation. Now, a CDH1 mutation will increase your risk of breast cancer, but it will also increase your risk of gastric cancer. So then the patient says to you, well, should I have a gastrectomy? But nobody in their family has had gastric cancer. So now you're sitting there going, geez, I don't know what to do. How do I interpret these data? So you can get yourself into a bit of a conundrum as well. So I think it's still a moving target. And I think the other issue is that it's so important to talk to your patient, if you're going to test everybody, about those VUSs. Because so many patients, they'll see the report that says a variant of uncertain significance, and they'll ignore the uncertain significance part, and they'll say, I have a mutation, when they don't have a mutation. And that we still need to follow up on those patients. So it's a moving target. I think you could go either way.
Dr. Chagpar, thank you very much for your excellent presentation. Thank you. Güzel ve sunumlarda oturumumuzu tamamladık. Katılımınız için çok teşekkür ederiz. Şimdi bir kahve arasının arkasından.
Yok, devam.